Marc, thanks very much for agreeing to talk at the KSS AHSN Respiratory Collaborative in October. Now, you're Professor of Medicine at UCL and Royal Free NHS Trust. So did your role change with the COVID pandemic? In what way?
Yeah, very much. Usually my job is 50% clinical and 50% research. And as soon as it became apparent that there was going to be an enormous clinical workload, I shifted to 100% clinical. So that meant a number of things. Firstly, closing down as efficiently as possible research programs, ensuring that the people who were involved in those programs working with me were okay. And what I mean by that is that those who were going into clinical, it was fine. But for a number of people, they were suddenly going to be based at home and they weren't sure if they actually had a future, which was important to manage. But then from what I then did, I then moved into a shift system that we set up here across the acute medical teams, which involved, of course, respiratory and infectious diseases. And so we would work 12-hour shifts in teams organized across the trust. We were lucky in that we definitely had good medical support and very good managerial support. And to me, one of the messages that I take away from COVID was actually, in an emergency, things can be organized to work in a very effective way, which I think is what we saw. What we found, and what I found in particular, was that after about three weeks or so of 100% clinical, actually things were starting to fray a bit at the edges. And I think that was both for individuals, but also in the way the system ran, because we had dropped so many things. I'm responsible, for example, for TB services. I was trying to sustain TB services with a much smaller TB nursing staff and almost no TB medical input, because the rest of the team had gone to manage COVID. And so I was trying to do my COVID job and also run TB services in a slightly ad hoc way. And that was very difficult to do. And so I then shifted back towards doing a little bit more of the TB service, a little bit less COVID. At about that time, because I can't seem to stop myself, I then moved back towards setting up COVID research programs as well. These were, as most of my research is, very clinically focused. So I was concerned, as were a lot of people, about what was going to happen to individuals with their COVID tail, as people now use that sort of slightly endearing term. What happens when someone's been sent home? And often we were sending home people probably a little earlier than we might do because we were running out of beds. And then where was their follow-up and how was that going to be and what sort of problems were we going to see? And so started to work much more, not just within one hospital, but across the patch. So across North Central London, North East London, using the footprint, for example, of UCL partners.
So lots of ramifications, and some of which particularly research that sort of passed some people by. So I'm guessing, Marc, that in London you've had a lot more cases than perhaps we have in acute trusts in KSS. Do you know your numbers?
Yeah, across we operate through two acute sites. There's Barnet General Hospital and there's the Royal Free in Hampstead. And across those two sites, we estimate that we had about 1,200 admissions. The reason we slightly are estimating that is that there was this tendency, as you know, that what do you call a COVID admission? We know how many cases were swab positive. We know how many were suspected, and it's that suspected group that is less clear. Of 1,200 admissions, we think about 30% died, which is astonishing. It's quite astonishing when you think, I mean, what other conditions do you see that number of people coming in over a very short period of time, and almost 1 in 3 of them not going to make it after they've come through the door? So we are left now with, because we're now doing the follow-up, we're seeing around 700 people in follow-up at the moment.
And I'm looking forward to learning from that experience. It seems increasingly likely there'll be some sort of second wave. Could you today just give us one example of something that you think would do differently next time around?
I think the front door assessment, I think, is really critical. One of the things that actually was being utilised already within, say, health services for the elderly was to look at a patient when they were unwell enough to present to an emergency department and have an assessment that was going to make a judgment call on what services did they need, not 48 hours in, but at the front door. I think what we will do increasingly is actually make the decision, does this person need to be admitted to hospital, or can we provide a level of support that is good enough, and that's got to be pretty good, at home, and if so, what sort of monitoring should we be doing? This concept of the happy hypoxic, in other words, an individual who has low oxygen saturations, who feels surprisingly comfortable, that teaches us a lot. That teaches us that we need to be monitoring people carefully and give them and their families a chance to actually put their hand up and say help if things aren't going right. So better use of services, I would say.
So thanks. So I look forward personally to hearing what you've got to say in October. I'm sure there'll be even more, then. And thanks very much.
Thank you.